Okay. All right, you guys, we're going to go ahead and get started. We are moving along throughout our six-part series with Dr. Monique May, our board certified physician and medical expert. And last week, I know you guys were with us for Why Should I Go to the Doctor If I'm Feeling Okay, part one. And this evening, we're going to continue with part two. So let's welcome and pass the torch to Dr. May as she presents to us tonight. You may proceed.
Thank you, ladies. It's so good to be in your presence once again. I'm going to go ahead and share my screen. I have to tell you guys, I reached a big milestone yesterday.
Right.
So you can see a little bit of the
Happy birthday.
Woo! I'm blessed. 50 years blessed. So I've been to 50.
Happy birthday, Monique.
Happy birthday.
It was a beautiful, beautiful time. So I, when I first started my career, 1999, I used to counsel patients on things. And, each year as I got closer and closer to those age groups that we talked about, it's like, oh, wait, I need to listen to this myself. So, it's so interesting how things change. So I apologize. My screen, my slides are not coming up for some reason.
Okay. Just to let you know, it gets better.
That's what I have heard.
It does.
I am okay with that. That is fine with me. It's been a oh, there we go. I can't complain. I've been very blessed. So, all right. I'm gonna start all right. So this week, we left you with a cliffhanger last week. So again, just as Gwen said, I'm Dr. Monique May. I'm a board certified family physician with over 20 years of clinical experience. I've worked in a variety of settings. I have my own practice. I've been in a group practice. I've worked in nursing homes, hospitals, occupational medicine centers. I've even done home visits in patients' homes. So a little bit of everything. So today we're going to talk about why should I go to the doctor if I feel okay? So this is part two to our discussion from last week. And so last week we touched on some of these, but I think they bear repeating as far as vision screening. Sometimes, people don't think about their vision until they start to lose it. It's kind of like you don't know, you don't miss your water until your well runs dry. And so then they know, oh, I need some glasses, or they'll go to the dollar store and get the readers. But at age 40, there's actually a term, presbyopia, which basically means, your eyes are getting older. And so, and that's just kind of the normal aging. But then if you add on top of that issues that can be abnormal, then you need to be aware of that. And again, please put your questions in the chat as we go along. And at the end, we should have time to get to all of them. So some of the things that a vision screening can detect that you may not be aware of or can catch kind of in its early stages are going to be cataracts. And that gives you that blurry vision, kind of like people describe it. It's almost like a Vaseline or a haze over their eyes. They just start to know that things are kind of dimmer than what they used to be before. They may experience glare at night driving. The oncoming lights may have an exaggerated or extra glare that they can't tolerate. Glaucoma is a condition where the pressure in the eye is elevated, and that can lead to actual vision loss, particularly in the visual field. It tends to be kind of the outer portion of the visual field, and that also too can have cause a glare at night driving. There's something called a glaucoma sus, which is where the eye doctor wants to watch you because your pressures are kind of, so just kind of like when we check your arm and you say you have, borderline blood pressure, we can see that with the eye as well. But fortunately, glaucoma can be treated with drops. Sometimes it will progress to needing surgery, but if you're under a doctor's care, that should be monitored closely. And then as far as cataracts go, the treatment for that is surgery. There's no drop for that. Another condition that can affect the vision is macular degeneration. And that's basically where a part of the retina. The retina is the back of the eye. There are blood vessels there. That's where the nerve, which is the nerve that carries, it's kind of like, think about it like the data cable that comes into your home. The optic nerve carries the information from the eye to the brain and vice versa. So if that part starts to degenerate, then you'll notice blurry vision, distorted images, and difficulty reading because it affects the center of the vision. So cataracts kind of affects the whole thing where you get this haziness. The glaucoma can affect the peripheral vision, and then macular degeneration affects the center. So where your vision is being affected gives the doctor a good idea of what you have. Another common condition, particularly in African Americans, is diabetes. So that will present in a variety of ways. We want to, if you notice blurry vision, particularly if the sugars are very high, the person is going to the bathroom all the time, they're thirsty all the time, that blurry vision, that tends to be a sign of a high sugar. And a person may have that before they are diagnosed as diabetic. Because again, they may just kind of shrug it off. Oh, I'm getting older, my vision's not as sharp as it used to be. But in fact, it's your body telling you that there's something going on that needs attention. They may also have floaters, which are little black spots in the visual field. You can lose parts of the visual field, and then they say that they have poor night vision. And then as the other thing you can have a stroke. The eye is basically an extension of the brain. So if there is, you can have a small stroke. My dad actually had a TIA a few years ago, which is a transient ischemic attack, which is like a mini stroke. It causes stroke-like symptoms, but thank God it doesn't leave the permanent damage that we see from a stroke. But when he went to the eye doctor I think earlier this year, late last year, they told him it looked like there were signs that he had a stroke in his eye, and he had never known that. So it certainly can happen. And he's been on actually glaucoma treatment for years now. All right, so next we have, my slides not advancing. Okay, hearing. So and again, we talked about some of these last week, but you may notice that as we age, that your hearing starts to decrease. And again, just like we have the term for vision called presbyopia, the term for normal aging loss of hearing, normal hearing loss due to aging is called presbycusis. So when you have that can be seen in normal aging, but we definitely want to make sure there is not something else going on. Some people have excessive earwax, and you probably, that's not something you would first be diagnosed with. If you've been going to the doctor throughout your life, not typical that you would be, reach your 50s, 60s or so forth before you're told you have a lot of wax buildup, because throughout your life, you probably have been in and say, I can't hear. And then they go in there and, get a chunk of wax out. I think my son may have this issue because he's had to have his ears flushed out 2 or 3 times now and get a lot of wax out of there. So some people just make a lot of earwax, and there's nothing wrong with that. It's nothing that needs to be treated or take a medication for, but it's good to know that, because maybe you can flush your ear out yourself at home, on a fairly regular basis to prevent the wax from building up. We don't recommend Q-tips, but you can get the bulb. They sell the kits in the store where you can kind of flush it out. There's stuff on Amazon that you can get, like, to kind of almost mimic what they do at the doctor's office as far as irrigating or flushing out the ears, but definitely not Q-tips. Another common thing we see is called tinnitus, which is typically described as ringing or buzzing in the ear. It can be in one or both ears, but people describe it as different things. Some people say they hear their heartbeat, or they hear a pulsing or a pounding. So, and it can be very disruptive, particularly at night when the person is trying to sleep, because of course, everything around them is now quiet, except for this noise in their ear. So that is something that should definitely be checked out, particularly if you do not have risk factors for that. And risk factors leads me to my next point of loud noise exposure. So occupationally, if you've worked, if you're in the military and around, heavy artillery firing or airplanes or anything where, you're exposed to over, I think it's 80 decibels is considered the threshold. Concerts, playing your music very loudly, as a younger person. All of those, of course, can damage the fine hairs in the ear that help us hear. And so, because once those cells die, they're gone. They don't come back. And so you want to protect your hearing, with earplugs if you're going to be exposed to loud noises. But damage from that can present as just that tinnitus, that annoying ringing or buzzing in the ear. And the treatment for that, unfortunately, is somewhat limited. White noise is what they recommend, where basically, if those of us who still have radios, when you're between two stations, that staticky sound, that can be helpful. Of course, now there's apps for everything. So I'm sure there's, the radio now has been replaced by white noise apps. But again, there's not really a treatment for that per se, unless it's caused by some underlying reversible cause. And then the other thing that we can see is a punctured or an eardrum with a hole in it. People sometimes stick things in their ear other than their elbow, which is what we recommend, and can go too far and poke a hole, which is one main reason why we do not recommend using Q-tips. But I've had people come in, they stick bobby pins in their ears, the big pin, remember the big pins, they'll take the cap, stick that in there, and then unfortunately can rupture the eardrum. One thing about excess earwax, I do want to say, is when people are addicted to Q-tips, they, people think, oh, my ear has to be clean. If there's any wax, I got to get every scrap of wax out. The people who came up with Q-tips, I guess it was Johnson & Johnson, they were brilliant, because I don't know how they sold us on something that is not necessary. Now, Q-tips have lots of uses for other things, but we don't need them for our ears. Because again, wax is actually a natural, your body makes it, and some people make a little, some people make a lot, some people make, thick wax, some people have thin wax, some people have flaky wax. It can be different colors. As long as it's not bothering you as far as causing pain or hearing problems, you don't need to bother it. And in fact, when you remove too much wax, you can actually get itching of the ear canal. And so then what happens then? Then you stick something in the ear trying to scratch it, and then you can, you lead to other problems like a punctured eardrum. So if that wax is not bothering you, don't bother it. You can use your washcloth, put your pinky in your washcloth, just kind of go around your ear when you're in the shower, and that is sufficient. So other things that can affect your hearing, again, like we mentioned for vision, it can, stroke can also be an issue. Certain medications, you may not realize this, which is, another reason when you go to the doctor, every time you go to the doctor, either, I recommend taking your actual medications with you, but at least have a list of the medications you're taking with the dosages, because there may be things you're not even thinking of. Aspirin in certain doses can cause that tinnitus we were talking about. Certain antibiotics can lead to ear damage or hearing damage, and then even chemotherapy. Some people on chemo will have some effects on their hearing. Diabetes, of course, it can affect that as well. High blood pressure can actually, and I was surprised to hear this. I had not known that before, but there is a correlation between high blood pressure and hearing loss. And then, of course, if you have a brain tumor, that can affect your hearing, particularly if it's on one of the cranial nerves. We have 12 cranial nerves, which are the nerves that are kind of in the brain versus the nerves that are in the body. And you can have a tumor on one of those nerves that can affect your hearing. I want to spend some time talking about mental health, because particularly now, it's just, this COVID has, of course, turned the world on its ear, so to speak, or upside down. And in addition to the logistics of not being able to see people and do things the way we used to do them socially or work-wise or education-wise, the financial impact this has had on many people. All of this is the perfect storm for just psychiatric or mental health concerns. And I saw a statistic that says that African Americans are 20% more likely to suffer some form of a serious mental health issue. And that, is a whole nother issue as far as the socioeconomic differences, the access to health care, all the things that you kind of hear about that can be applied to just about anything as far for African Americans living in the United States. But mental health concerns can manifest in a variety of ways, such as memory problems. So again, some people say, "Oh, I forgot where I put my keys." It's just a sign of getting older, and it certainly can be. There is a normal forgetfulness that we see with aging, but when it's not normal is when it is persistent. If it's progressive, if you go to the store and can't find your way home, those are things that are definitely not considered normal. So, occasional forgetfulness, going into a room, forgetting why you're there. I think, who here hasn't done that? But if you're noticing that those episodes are increasing in frequency, that should not just be shrugged off. Insomnia. 5% of Americans suffer from insomnia and 50% of the elderly. And by insomnia, we mean either difficulty falling asleep. So you go to bed, 10 to 15 minutes later, you're still awake, you're tossing, turning. So difficulty falling asleep or staying asleep. So you're able to fall asleep, but you wake up because of, not because you have to go to the bathroom or you're cold or hot or something, but you're just waking up because you're not getting that restful sleep. That's considered insomnia. So that is fairly common. Anxiety, we see that in about 40 million Americans per year, which is about 18% of the population, but only about 1/3 get treatment. And when you talk about certain populations, and particularly African Americans, you have to wonder how accurate these numbers are, because people don't always go to the doctor for these things. Because what do we do in the African American community? Oh, we're going to pray about it. Or you need in men. Men don't cry. Men don't. You man up. You don't put a name to that. You're not going to claim it, right? I know you all have heard these phrases, but that's really doing everyone a disservice, because just because you don't claim it, that doesn't mean it goes away, and so people may go to the doctor for pain. Oh, I'm having headaches, I'm having backaches, I'm having all kinds of things, and the underlying problem is really their anxiety or even depression, but it's not being diagnosed correctly, it's not being treated correctly, and it's manifesting in other ways. If a person is always angry all the time, well, why is that person always angry? Like, what else is going on there? So, you add in the cultural kind of reluctance that we tend to have overall just as Americans, but then even within our own community, especially faith-based communities, we're doing a disservice to people suffering from this, because it's out there, it's common, and fortunately, things are getting better as far as we have commercials advertising different medications. People are sharing more. Some people may think we're oversharing, but when you see that you're not alone, it does normalize that, because some people, when you're dealing with something, the first response, or one of the first responses is, I'm no one else knows what this is like, or that you have failed somehow and you have brought this upon yourself, or what are people going to think about me? So all of these things, or we don't put our business in the street, we don't talk about what's going on at home outside. So all of those things work to isolate the person being bothered by this and preventing them from getting the care, the treatment, whether it's talk therapy, medication therapy, group counseling, family counseling, a combination of all of it. That is what ultimately should be the goal, to get that person to his or her full mental health, because mental health it affects the body. It's not just mental. The mental disease, not feeling well, can manifest as physical symptoms as well, like I mentioned, back pain, chronic pain, abdominal pain, all kinds of ways. Patients go through, get $1 million workup, and we can't find anything that we can point to or cut out, and it's just because of what's going on. I'll tell a story here, and actually let me and then as far as depression, the numbers quoted are, it affects 1 in 15 adults. per year. I'll share, and I may have shared the story before, but it fits here as well too. When I was early in my career, probably no more than about 5 years out, um, I was very much by the book, and patients don't always read the book. And so I had this diabetic patient, sweet African American lady, and she was on a variety of medications, and I knew she was depressed. I knew she was seeing a psychiatrist. I knew she had, but as her family doctor, I was really just concerned with her her diabetes. So right there, I made my first mistake because I wasn't treating the whole patient. She was diabetes. Like, it was this nice little box, and I'm just going to deal with what's in this box. Well, she would keep her appointments. I couldn't ask for a better patient as far as keeping her appointments. She didn't no show. We scheduled the appointment, she would come. But we were not getting anywhere. Her numbers would always be horrible. And I'm increasing medications. My prescription pad, I can write prescriptions all day. And one day something just said to me. I heard this voice, and I believe it was God, because I have faith that He gave me the skill and the talent as a physician. So, and it said, look at her. Look at the patient, because I'm in the chart. I'm down here. Oh, your A1C is this. Your microalbumin, your urine protein level, your eyes need to be checked, your feet, all the stuff we tick off for diabetics. And something said, look at your patient. Basic, right? But in the hustle and bustle of a busy practice, I had overlooked it. And sure enough, I looked at her, and she was textbook depressed. Poor, posture, poor eye contact, looking down, not smiling, not really interacting with me. So I said, well, what's going on with you, Miss So-and-so? And she admitted. She said, I want to die. She said, I'm trying to die. And instead of taking a gun or something, definite and finite and immediate, her thought was, well, if I just don't take care of my diabetes, eventually I'll die from the complications. And this was a fairly young woman. She was in her 50s. She was not, an older person. I got up from my seat and went out and called her psychiatrist. And I said, I have so-and-so here. And I think you need to put her, I think she needs shock therapy, because she was on a list of medication. I mean, and that's kind of why I had never really clued in, because the psychiatrist had her on almost as many medicines for her depression as I had her on for her diabetes. So I call him and say, look, she's here. She's just told me that she wants to die, passively aggressively. She's trying to kill herself. So, what's the plan? I said, I think she needs shock therapy. And for those who may not know, for severe cases of depression, we actually can do shock therapy, which is where they take the person into the hospital and administer a low dosage of electricity to the brain. And the thought is just to kind of reset the synapses, the chemical pathways in the brain, to just, reset, kind of like doing Control-Alt-Delete on your computer when it's acting up. So sure enough, she went straight from my office to the hospital, got the treatment, and the next time I saw her, she was a completely different person. She was smiling. She was engaging with me. She had great eye contact. Guess what? Her diabetes improved because now she had something to live for. She wanted to live to see her grandbabies. She wanted to be here. So how much time did I cost her by not cluing in on that in the beginning? So she taught me a very, very valuable lesson, that when, people are not responding the way you think they should to a treatment, look deeper and look for what else could be going on, because that woman could care less about her sugar. I was in there fixated on getting her to the goals, the national goals and targets that I know she should be at. But what is that? What is that to a depressed, suicidal person? So it taught me the very, very valuable lesson of looking at and treating the whole patient. All right. And then at your annual or check-in with your doctor, they may discuss some safety issues. Some of these we think about with children, but they're important with adults as well. In the home, particularly as we get older, and we've talked about some vision issues, you may have balance issues. So we want to make sure that the home is well lighted or well lit. If there are rugs, that they are not where you can trip over them, area rugs where you can trip, that all the rugs should be secured or just taken up altogether, because particularly if someone has a walker or a cane, you wouldn't want that to get snagged on the edge of the rug. Stairs, make sure they are well lit, or if a person has difficulty, maybe investing in the electric chair that kind of goes up and down the stairs for the person so they don't have to walk. Making sure that the detectors are working, smoke detectors, carbon monoxide detectors. Does anybody know when you're supposed to change your batteries? Put in the chat for me. When are you supposed to change your batteries on your detectors? Let's see who knows the answer. There's something that we link it to that we recommend. It happens twice a year when we tell people to check their, let's see, every 6 months. Yes, but there's a specific thing that happens that daylight savings time. There you go. Daylight savings time. So when we change the clocks in the fall or the spring, that's a good time to check your detectors. But it can be whenever you want. If you want to do it on your birthday, if you want to do it, New Year's Eve, whatever, just as long as it's something that you're going to be doing, on a consistent basis. Driving issues, of course, distracted driving is a significant issue in this country. As we get older, we may, start to lose some of our driving skills as far as reaction time. Again, if we've had a vision or hearing issue, so that might be something to be addressed. So just basically assessing how safe someone is to continue driving might need to be looked at as well. Weapons, I realize I'm in the South, and well, actually in the United States, there are more guns in this country than there are people. And so, but if you, for the responsible gun owner, making sure the weapons are locked away, secured, unloaded, particularly if there are children in the home. Again, if you have a person who is dealing with a mental health issue, making sure those weapons are not easily accessible to prevent something tragic happening. And then elder abuse. I don't have exact statistics to quote on this, but unfortunately, just like children can be abused, elders can be abused. And, if we see this when the caregiver is stressed out, or if so that person doesn't have a support system, they may be sandwiched in between, their children, caring for their children, and then caring for a parent. If the elder has a lot of health problems and can't really participate in their care, we may see the rates of elder abuse go up there. So that is something that should be at least thought about. Again, if someone is coming in with unexplainable injuries or injuries that just don't make sense with the history, the story, again, just like with child abuse, there are certain things that you can tell from the history, that activity or that injury shouldn't have resulted in what we're seeing on the skin or, broken bones or so forth. So, and then similarly, domestic or intimate partner abuse. And this can be, male or female in heterosexual or homosexual relationships. But again, a woman may come in just complaining of various things that on the surface don't really add up. But if you don't ask the question, you may never know. You may never find out. So those are the things that we have to ask about safety and do you feel safe in your home? So we're going to wrap up with just, yeah, you're telling me all this stuff about going to the doctor, but lady, we're in the middle of a pandemic. Now that we have Corona, now that COVID-19 is here, and we don't know what's going to happen, in the fall. There's projections that we're going to get another wave of it. We honestly don't know. But as a physician, someone in the medical field, I can tell you that the practice of medicine is forever changed in this country. It is not going to go back to exactly how it was. And some of that is good. Some of that is not all bad. but traditional visits are a thing of the past thanks to COVID-19. COVID-19 has disrupted everything. And so, and medicine and healthcare is no exception. So while you will be able to go back to the office, I mean, we were doing a lot of telemedicine. I also do telemedicine services. And in the first several weeks of this, we were slammed because people couldn't get into their doctors, and we were telling them not to go to the emergency room unless it was truly, life or death. So telemedicine became a very viable option. One of the good things that I see coming out of this is that the insurance companies are going to have to change their reimbursement for telemedicine, because before Corona, some insurance companies are paying for it, but not a lot. And we know that a good number of doctor's visits are really unnecessary. I'm just going to be honest with you. Some things can be handled in a telemedicine visit. Some of the yearly physicals that we do, we don't always necessarily need to do everything every year. If your cholesterol has been checked, does it need to be checked every year? Not necessarily. If you have a low risk profile, you don't necessarily have to get all your blood work done every year. So some of the stuff that we've been doing, even when it comes to pap smears, we know now that every woman doesn't need a pap smear every year until she dies. That's just not how it is anymore. So these services and the care that we can provide via telemedicine should be reimbursed. And so dealing with insurance companies and kind of dragging them into the new world is what's going to really propel this forward. But yeah, there's going to be more to that. And so I think a mix of in-person visits and telemedicine visits, particularly with, the wearable technology that we have. When you can monitor at home, if everyone's got a smartphone, you can get certain vital signs done with that. You can get scales that communicate, via Wi-Fi, particularly in patients where weight management is an issue, like people with heart failure or kidney failure, conditions that make you retain fluid, and just a couple of pound weight gain is significant. Because it's a sign that you're getting into trouble. Things like that can be uploaded and communicated to the doctor's office, and medications adjusted, or dialysis or what have you. So as the technology evolves, and as Wi-Fi and internet become more available and affordable, there's no way that healthcare can remain the same as far as how we practice things. And so going forward, doctor's visits are going to be done in a variety of ways. So you have, of course, the traditional office model that we have, but we've talked about the telemedicine visits. There's also something called concierge medicine, which, and some of you may have this is already out there, but I believe some of these models are going to become more common and more widely known. So basically, we have concierge medicine and we have direct primary care. They both are a monthly fee. So you sign up for yourself or your family member, and you pay a certain amount each month, and you get personal one-on-one care with your physician. And that can include anything from 24/7 access. You can call your doctor at any time, to if you do end up needing to go to the hospital, your doctor will meet you there, will care for you while you're in the hospital. It's really a one-on-one personalized approach to care. And it's better for the doctor because they don't have to see as many patients. Your doctor may have more time to spend with you by seeing fewer patients. And that may sound crazy. How can the doctor have more time if he's seeing fewer patients? Because this model cuts out the insurance companies for the most part. You are paying the doctor, your subscription fee, just like you pay for your Hulu or your cable or phone or whatever. You would pay your doctor a monthly fee, and the doctor would manage your care from that fee, whatever lab work you need, whatever imaging or x-rays you need. So ultimately, it's actually a more time efficient, and it's also actually a cost savings, because a lot of stuff that we do now, some of the testing we do, again, is unnecessary, or we're repeating stuff. You go here, you get this test. You go over there, you get the same test 2 weeks later, because there's no communication, or there's no central warehousing of your records, sometimes. And so what does that do? That drives up the cost of medicine, of healthcare. What you're doing, duplicating unnecessary tests. So by having this model, by having your doctor who knows you, and it, and can provide the care that is personalized to you, cost effective, time effective, these are going to be, I think, the wave of the future. And again, as insurance companies come on board and see the value in them, that's going to help as well. The doctors that I know who do this, they don't deal with the insurance company, so you would pay the doctor up front, and then you would be able to submit to your insurance company for reimbursement. So these models came out of doctors' frustration with the insurance company. The hoops that we sometimes have to jump through. And so by cutting out that middleman, they can keep their costs low, yet provide good care to their patients. And then the patients can see what they can get reimbursed, but the doctor has, removed his or herself from that. So there's more to come on that. Definitely look out for that. If your doctor, some of you here may know, I used to go see my doctor. She used to be part of so-and-so, and then she went out on her own. That's because, she may have opened one of these type of practices where you sign up. The concierge medicine versus direct primary care tends to be, those can be a little bit more expensive. The direct primary care model may be more for the blue collar, lower socioeconomic class, whereas the concierge model may be a little bit more pricey for that income range, but basically still the same concept. And that's it. That's all I have for now. So thank you for your attention, and I would be happy to take questions.